Still letting everybody in. How's class? How are you enjoying this class so far? Garcelle gives me a.
It
They
makes my
do.
anxiety go up.
What?
I say it makes my anxiety go up.
Oh, that's not good.
I do like the way you teach the class, I will say.
Oh, thank you. I mean, basically, my lecture notes that I use are the notes I send you guys. So I like to go from the notes because that's been a review that I've done to put together those notes, and I think it's helpful so you can follow along and take notes on those notes. Just trying to get everybody in. Gosh, this is a big class. Okay, how many do I have? 36. We're still waiting for a bunch more, but okay. I just need to send one student a message in the chat. Okay. All right. So, I said, welcome to week 5. We've still got some people checking in. So, how's everybody doing?
Good.
Good? Okay. By this week, you should be well organized with all your classes, right? Oh, 1 second. Just again, letting people in. Hang on. You should be organized with all your classes. I see people coming in that have already been in. Are you guys having trouble getting in, or what's the problem? Let me find out from this group. There's people that are coming in for a second time, or you guys having problems getting in, or what?
Yeah, we originally signed in through our phone because we're leaving the class. So we signed in from our computer once we make it to our destination.
Okay. Okay.
Okay, thank you. So
Okay.
see, Miss Marble, they the ones coming from a class.
Pardon me?
I don't know what campus they're from, but they're the ones coming from a class.
Okay.
Essington don't come from a class.
Okay. Thank you.
Okay.
Who is iPhone? I don't know who iPhone is. I need everybody to be on camera, please. I'm looking at ceilings and I'm looking at walls.
Progress.
iPhone.
Yes, ma'am.
Who is iPhone?
Suriba Kamara.
Okay, can you switch your name on your iPhone?
I'm doing it now. It's all right.
Okay, thanks.
Thank you. You're welcome.
No worries. And everybody, if you could just make sure your background is unclear and not blurred, I would appreciate it. That'd be great. Okay. Amelia, I can't see you. Which campus is coming from another class?
Port St. Lucie campus.
Port St. Lucie is coming from another class. And what time does that other class get over?
Exactly at
Supposed-
12:20.
12:20. Oh, okay. So you
Yeah,
still
it's our
have,
med, it's our
still
med
have-
surg class.
okay, and you still have 40 minutes before this class starts. Is that correct?
But you have people that have to commute. I drive an hour to get to my campus.
Right.
Yeah, so
Right.
do I.
So that's why I think it's suggested to just stay on campus. If you're not going to be able to make it home. I think that came up last term as well. I thought I saw nobody's driving, right? Nobody's driving. Nobody's in their car. Somebody, yeah, Danya, you're in your car. I can't. Danya? Pardon me?
I sent you a message. I'm coming back from an appointment. I was stuck in traffic.
Okay, well, you're gonna have to log off and then log back on when you get home.
I'm not driving though.
It's okay. It's the
Okay.
policy. You can't be in the car. I'm sorry. Okay. Okay, still letting people in, so I apologize for the distractions. Okay, let's get going. It's week 5. So a couple of things. I sent you all your groups, okay, earlier this week. So you all have your groups. I know you're from different campuses. That's what happens when we have an online class. So the goal is for somebody to take the lead to send out an email to your group or a phone text. You can use this chat today. Nicole, if you want to stay on after, we can address that.
Yeah. I can.
Okay.
All right.
Okay. Groups. So somebody needs. I actually, Natalia, you're in the chat. I have 4 tutoring sessions set up after this exam. So if you're not one that's part of that group, if you could send me, I've got a couple of messages to meet for exam 1 review. So if you're not in that group of 4, 4 separate tutoring sessions after this class, and you do want to go over your exam, if you could just please send me a couple of days and times that work for you, I would appreciate it. And then we can get something on the books. Okay. I've actually heard from a lot of students that want to review the exam. I've already done several tutoring sessions this week, and they've been, I think, extremely helpful for students. So especially if you score below a 78, I really think it would be beneficial for you to meet with me, and we'll review the exam and what concepts you missed. Okay, and then if you scored above 78 and would still like to meet and review what questions you missed, that would be fine too. So I'm happy that the invitation is extended to everybody. Okay? Anybody have any questions about exams? I mean, overall, the scores were the average for the let's see, the average for all the 6 sections was over an 80. So that's really, really, really good. For 6 sections, really, really good. So overall, the scores were quite well. I was very proud of you guys. So congratulations. Let's see. I texted you, so no. Darlene, nope. I texted you back or messaged you back and said I had several tutoring sessions after this. So you're gonna have to send me some other days and times. Okay. Going back to group. Okay, going back to groups. You all have your groups. So the goal is for somebody to take the lead and send out a message to figure out which part of the group project that you each want to do. Okay. Then a couple of things to remember. Don't submit me all of your individual parts. What you need to post into the discussion thread is the final project. Okay. So I realize I'm going to be getting five copies of the same paper. I get that. But in order for it to populate in the grade book for you to get credit for it, you have to submit it. The whole group has to submit it separately. But I know you're submitting the same thing. And then this goes into a discussion thread because this is a project that you respond to 2 peers with. So it can be submitted a couple of ways. You can do an actual paper on a Word document that has a cover sheet with your names on it, and you can submit it to the discussion post as an attachment. That's fine. Or you can copy and paste it and put it into the discussion thread. Okay, either way works. And remember that this project, and it's on your assignment's due date, the project is actually due on the Wednesday of week 7. Right? It's treated just like a discussion question. It's due on Wednesday. And then you have till Sunday to respond to a couple of your peers' projects. Does that make sense? Okay. So go ahead.
Yeah, I just want to get it straight. You said each person is going to same thing, each person in that group, or the whole group will do submit one?
All of you in the group will divvy up the parts of the assignment, right? And then somebody's going to organize getting it all put together. And then you'll be submitting one final paper, all of you. The same thing.
Same thing, okay.
Yep.
Miss Marvell.
Mhm.
Would you take like PowerPoints or slides for this project?
It's not a PowerPoint or slide project. It is a paper project. Your vulnerable populations assignment in week 10 is the PowerPoint.
Okay.
So this
Thank
is a
you.
Word. You're welcome. You're welcome. Any other questions?
I just kind of have a question. If there is a classmate I haven't been able to get a hold of, what do I do about that?
You email me.
Gotcha.
You email me. But remember, we're still in week 4.
Yeah, it's
Okay.
not due until week 7, right?
It's not till week 7. So if you want to use this chat to try and communicate with anybody or send phone numbers to each other, that's perfectly fine.
Okay. All right.
Okay.
Thank you. I appreciate it.
Sure.
Week 5, no, it's 5.
Pardon me?
Say this is week 5. We only
Right.
got 2 weeks.
Oh, this
You
is
said-
week 5, right? So it's due 2 weeks. So it's due 2 weeks from today.
Yes, ma'am.
Did I just say it was week 4? Sorry. And we're going to cover contents of week 4 and 5 today. We have 8 different concepts to cover. So we're going from week 4 notes or blueprint notes and week 5 blueprint notes. Okay, and then we'll take quiz 3. All right. Okay, Any other questions? Okay. All right, let me share my screen. And we'll start with week 4. Okay, so last week the content was certain special vulnerable populations. Okay, we pregnant adolescents, LGBTQ, mental illness, and alcohol, tobacco, and other drug problems. These are in the community. These are considered special vulnerable populations. I want to point your attention to the readings. Okay, I outline the readings for you, but you also have 3 Canvas course teaching sheets in your module. One for pregnant adolescents, one for LGBTQ, one for mental illness. So everybody knows where to find those, right? And knows that they're part of the reading assignment. So I'm not going to go through those. Those are a supplement to the notes. Okay, what do we know about special vulnerable populations, especially these ones? Right? We know that they typically have poor health outcomes, right? Increased morbidity, increased mortality. They have an increase in chronic illness. Okay. They may have an increased incidence of poor living conditions, poor nutritional status, may be exposed to more crime and violence, domestic violence. Okay. Pregnant adolescents are of particular concern as a special vulnerable population. Why is that? Let's talk about pregnant adolescents for a minute. What are the dynamics around this as nurses that we should be concerned about?
Since
Their
their nutrition, their dietary needs.
Okay.
The baby gonna be have a low birth weight.
Yep. Potentially. Yep.
Risk for poverty and lack of education. They tend to possibly have can also have increased risk of dropping out of school, end up getting sexually abused or violent or physically abused, increased risk of mental problems, mental disorders because of the self there's kind of like looking at themselves differently because they're kind of at that stage in their life of worried about how their weight and their looks and everything in the popularity.
Exactly.
Homelessness.
Homelessness is a
higher risk for STDs.
Yep. Yep. So pregnant adolescents are considered especially vulnerable. Okay. They're 3 times more likely to drop out of school. Okay. So one of the things that working with pregnant adolescents that we want to make sure of is that they have every opportunity to continue with their schooling during their pregnancy. Okay. It's found that if they can continue their schooling, they may be better prepared, better educated to make more conscious decisions, better decisions. Right. And it's also considered helpful because it improves their health care over the long term for both them and their baby. Right. So it's really important to keep the pregnant adolescent in school. Okay. And then try and return to school as soon after birth as they can. Okay. We know that pregnant homeless women have several challenges. Higher rates, like you said, I think Julia said it, sexually transmitted diseases, higher rates of addiction, drug and alcohol, poor nutritional status, and maybe in a higher incidence of poor birth outcomes. Right. So being homeless and adolescent and pregnant is it's kind of the worst of the worst situation. Okay. Typically, racial and ethnic minority groups have a higher rate of teen pregnancy. And that's related to also having a higher rate of poverty. Decreased educational opportunities, higher rates for abuse, sexual victimization. right? And some factors that contribute to adolescent pregnancy: low income, lack of education, lack of social support networks. They don't want to tell anybody they're pregnant, right? So they may wait. They may wait and seek prenatal care in the second or third trimester. Right? And then certainly their living environment exposures, abuse, trauma, neglect. Right? So teens that are pregnant are typically caught up in a cycle of poverty, the cycle of school failure, right? And they are more likely to be homeless, right? And they're much and domestic violence is very prevalent in teenage pregnancies. Okay. If you're doing, let's say you're doing a postpartum visit, let's say you're a community nurse and you're doing a postpartum visit. The mom and the baby have been home for a couple of days and you've been assigned to do the new baby visit. What kinds of things are you going to look for that are positive and that are concerning? What do we want to see the mother doing?
Oh, like
Breast-
breastfeeding.
Bonding.
Bonding and nurturing the
Binding
baby.
with the child.
Yep, exactly. Meeting the baby's needs, right? Having an idea of how to meet the baby's needs, feeding needs, diaper change needs, bonding, eye contact. Okay. That is Healthy People 2030. One of their goals with regards to adolescent pregnancy is to increase the exposure of support that the adolescent mothers have after they deliver and they get home. Remember, these are kids. These are kids having kids. Okay. So here's a couple of examples of primary, secondary, and tertiary prevention with regards to teen pregnancy. What could we do to help prevent that? Maybe developmentally appropriate sex education, right? The sooner these conversations happen, the lower the risk of an unintended pregnancy or an STI. Okay. Parents should be educated as well on the necessity to provide sex education to their kids in the home early. They should have education on reproductive rights, where to find contraception. Those are all preventative interventions. Secondary, how do we go ahead and identify the teens that are maybe at higher risk for an unintended pregnancy? How do we identify the risk students? Maybe they have substance abuse issues. Maybe they have a history of sexual or physical or emotional abuse. Maybe they live in poverty. Maybe they're poorly educated. These are vulnerable kids. Okay. And then in tertiary, the assumption is they're pregnant. So what kinds of things do we need to be concerned about? Prenatal visits, nutritional status, support. Okay. We talked about school, getting back to school as soon as possible. And then we already talked about bonding. Okay. So that's an overview of teen pregnancy, considered a very vulnerable population in the community. Okay. There's also a teaching sheet in your module on that, and same with the LGBT population. Okay, so as nurses, we have the ethical obligation to provide culturally competent care to LGBT families. We actually have the obligation to provide culturally competent care to everybody. What do you think I mean by culturally competent care?
Understanding the patient's religion background and their cultural beliefs.
Providing care around their cultural beliefs. Like for example, if there's someone who is Jewish, you're not going to want to I believe it's Jewish. You're not going to want to give them. You're going to want to make sure that their food is blessed in a certain way. And I don't think they can have blood transfusions either.
Yeah, so culturally competent care means that we are aware.
Sorry, go ahead.
No, go ahead. Go ahead.
Being aware of the patient's
beliefs and their rituals.
Right, exactly. Yep. Being aware of their beliefs, their values, their practices. And I'm just talking in general here before we get to the LGBT community. We have to be able to seek out the knowledge of different cultures. I mean, in nursing, it doesn't matter where we're going to work. It doesn't matter what setting we're going to work. We're going to be working with different cultures through our entire profession. All right. You're not, I mean, I'm still learning about different cultures and I've been in nursing for 40 years. Okay. If I don't know certain things about a culture, I ask. Okay. It's perfectly okay to ask. We want to know about different values, culture, values, beliefs, practices, because, pardon me, ultimately, we want to try and incorporate as much of their culture into the healthcare plan, right? So with regards to the LGBT families, we do have an obligation to provide culturally competent care to these families as well. And some nurses may have a degree of discomfort discussing sexual orientation with their clients, right? But we as nurses need to, if we are uncomfortable, we need to overcome the barrier with these families, right? We need to be able to provide a safe environment for them to discuss their sexual orientation, right? We need to check our own feelings, understand our own feelings in providing care to this population. Okay. One of the ways to do this is to take an open, non-judgmental sexual and social history. Okay. In order to do that, let me take a step back. We have to build trust. Okay. Not only with this population, but with every population. But we're talking specifically with this population now. Okay. To build trust, we need to be open, non-judgmental, not making assumptions based on their appearance or their language or whatever. Okay, we need to be asking open-ended questions. All right, so rather than assuming heterosexuality, or we need to be able to say something like, instead of "Are you married?" maybe we say, "Do you have a partner?" Right? Are you in a, let's see, are you in a relationship? What do you call your partner? Those are kind of non-judgmental, open-ended questions. We have to provide a level of comfort and trust for them to be able to open up to you. Okay. CDC has recommendations on screening. Okay. For the prevention of sexually transmitted diseases. Okay. And these are very specific, and you're going to get asked about these. So please know these. Okay. So there's an annual screening for several things. It's right here: HIV, genital herpes, syphilis, gonorrhea, chlamydia. Okay. The recommended screening interval is shortened to 3 to 6 months for those that are particularly high risk. Those individuals at high risk are considered people that have multiple or anonymous sex partners, or those who use illicit drugs in conjunction with sex. Okay. So in our community nursing role, the goal of working with the LGBT is providing them a non-judgmental, trusting environment to be able to discuss what their health issues are. Okay. And they also teaching them and informing them of what the CDC recommendations are for annual screenings. Okay. Anybody have any questions about that? And again, supplement that information with the page in your module. Okay. Mental illness. Mental illness is exploding in our country. Would you agree? Exploding. Okay. Anxiety. Anxiety is a big one. Okay. Anxiety is normal. Anxiety is common, right? Unless it becomes debilitating. There are lots of things we're anxious about in our daily lives, right? But if it becomes debilitating and impairs our function to, function to the fullest extent, then it becomes more towards a mental illness. Okay. So there's a couple of mental illnesses that I want to talk about. One is general anxiety disorder. This is the second paragraph. It's called GAD. Okay. So there's actually five. I want you to know about general anxiety, the differences between general anxiety disorder. I'm just going to highlight this for you. Then somebody needs to mute with all the background noise, please. Then we have a phobia.
Can you zoom in, please?
Sure. You mean make it bigger?
Yes, I can't see.
How's that?
Thank you.
Yep. Okay, so these are the disorders I want to focus on for purposes of this. Okay, these four. There's going to be questions on them during the exam. You're going to be given scenarios, and you're going to have to identify which disorder this is. So we need to know the differences between it. So generalized anxiety. Persistent, unrealistic, or excessive worry about two or more life circumstances for at least 6 months or longer. I'm just giving you the general definition. You can read through the rest of the paragraph. Phobias: experience excessive irrational fear of a specific activity, situation, or object. So, for example, I have an incredibly big phobia against snakes. I'm also claustrophobic. I'm not making that up. Okay. OCD. So somebody with OCD may experience obsession, recurrent or intrusive thoughts that they cannot stop thinking about. And the thoughts create anxiety. Right? A compulsive act is an act that somebody feels compelled to perform. We all know somebody that has OCD. And then PTSD, characterized by an event, a previous event that's involved threatening death, serious injury, car accident, in which somebody's experienced intense fear, helplessness, or horror. Okay, and that common remembrance of such events produces those feelings of distress along with extreme anxiety. Okay, so those are the four we want to know about. Here's a very important fact. Children are at the highest risk for mental disorders. Okay, secondary to adverse circumstances, and they're at the highest risk for ongoing disruption. And that goes along with our theme in this class that children are most vulnerable living in poverty. Okay? Children are extremely high risk. Okay? And then the one drug I'd like you to know about is lithium. Okay, what do I want you to know about lithium? Okay, why do we use lithium? We use lithium as a mood stabilizer for a bipolar disorder. The few teaching points for lithium are encouraging normal salt intake and report any of the following: diarrhea, vomiting, tremors, lack of coordination. Okay? That help?
Yep.
Okay. Last special vulnerable population is, we call it ATOD, alcohol, tobacco, other drug problems. Okay, where do we start? Where do we start with alcohol, tobacco, and other drug problems? It's everywhere, right? We know that substance abuse in general contributes to teen pregnancy, HIV, STDs, domestic violence, child abuse, motor vehicle crashes, fights, crime, homicide, suicide, and much more. Right? We know that tobacco contributes to cancer, heart disease, lung disease, maybe premature birth, low birth weight, stillbirth. Okay. So what are some factors contributing to substance abuse? Okay. What kinds of factors do you think contribute to substance abuse? Behavior?
It could be stress.
Stress, their moods, things that are going on in their personal life.
Mhm. What about hereditary?
Yeah.
What about environmental? The community they live in?
Poverty.
Poverty, exactly.
Mental illness.
Mental illness. Lots of things contribute. There's a gazillion things that contribute to substance abuse, right? Mental illness is a big one. Okay? People try and self-medicate. Well, if you even think of post-surgical patients or pain management, right? What about social influences? Peer pressure.
Yes, that's a big one.
Huge one. Huge one. Here's some terms and definitions. I just want you to read through. No need to memorize any of this, but be able to tell the difference. Substance abuse, drug dependence, addiction. What's alcoholism? What's polysubstance abuse? When you're using more than a few prescriptions. What are some examples of psychoactive drugs? What's a depressant? What's a stimulant? What's an energy drink? Okay. Nicotine. So nicotine, tell me about vaping. If you were doing an education with parents about teaching them how to become a smoke-free home, and a parent said to you, well, I'm now smoking outside. Is that okay?
Nope.
It's better, right?
Mhm.
Better. What if they tell you they're vaping? Don't worry, we're fine. We're vaping now.
That's
that
more
okay?
dangerous than a cigarette.
Why?
Mhm.
It can
Just-
poison the kids.
What poisons the kids? The oil.
The oil.
Exactly. Exactly. So obviously nicotine, tobacco, when I was in the schools for 22 years, I did tons of teaching at the middle and high school level about prevention teaching about the effects of starting to smoke or starting to vape. Okay. We know that lung disease is one of the costliest chronic illnesses in our healthcare system. Okay, it contributes to cancer, heart disease, lung disease, emphysema, bronchitis, COPD, right? Alcohol. Alcoholism costs our country billions and billions of dollars a year, lost productivity, property damage, medical expenses for alcohol-related illnesses, family disruptions, violence, neglect. Okay, causes lots of physical, cardiovascular, hypertension. I mean, lots and lots of physical conditions. I have this highlighted because I want you to be aware of that. If to to assess what a BAC, blood alcohol concentration is, it's not, a lot of people think it's just measuring how much you drank. Okay, but there's several factors that go into this. Okay, it's determined by several things: the concentration of the liquor you drank, the rate of the drinking, the rate of absorption, the food that you've eaten, the rate of metabolism, people's weight and sex. Okay, so if you're asked a question about how do you figure out what a blood alcohol concentration level is, you have to understand, I guess what I'm trying to tell you is it's not just one factor, it's several things. Okay? Just because I'm skipping through this and highlighting doesn't mean that you're not responsible for all of it. Okay, so please read through your notes. Amphetamines and methamphetamines. Okay, the rest of it you can read through on your own. So that's covering general overview of alcohol, tobacco, and other drugs. Okay, look at our fentanyl. Look at fentanyl. What is fentanyl doing to our country?
Crazy.
It's killing them.
Yeah. In absorbent, I mean, extremely high numbers. So let's cover the concepts from this week. Okay, we're going to shift gears here. Did I not share my screen here? Let me share. Okay, now you can see it. Okay, we're going to definitely shift gears here to hospice, palliative care, death and dying. What's hospice? Has anybody ever worked in hospice, worked with dying clients? What's hospice?
Just to make them comfortable, but you still tend to, like, whatever is pre-existing, you still treat them, but you make them comfortable in their last days.
Yeah, it's end of life care.
Right.
Right? Hospice nurses are just absolute guardian angels. I had to work with hospice nurses with a couple of family members in the last few years, and they're just like no other. Okay, so this is end of life care. Okay, where we focus on keeping the client comfortable and trying to maintain dignity and self-esteem. Okay, pain management is important. However, we don't want to keep the client so sedated that they can't interact and be totally unaware of what's happening. Right? If the client is able, we would like for them to be as involved in their care planning as possible. It's called autonomy. All right. We know that in hospice nursing, the family is also a very important part of the role of the group with the client, but always the client comes first. Okay. So if the client has a living will that says, I don't want any more treatment, I don't want any more feeding tubes, I don't want any more, and you have a family member, they say, no, we want a feeding tube put in, we want to prolong this. No. Okay, we go with what the client's wishes are. Okay, but maintaining comfort and dignity is the most important. All right, in hospice and palliative care, the goal is to alleviate as much suffering as possible. Okay, without attempting to cure, improve. We're trying to improve the quality of life. Okay, it's quality versus quantity. Okay, and we know that in hospice, there's no cure. Right? So the client has to be fully aware that there is no cure for this. Okay, so if a client says, I'm waiting on some additional treatments that my doctor said might help, well, they could translate that into maybe help live or cure my disease. So we need to make sure the client is crystal clear there's no cure for what they have. Okay? So in addition to symptom management, hospice patients may also receive psychological and spiritual support. Okay, really important. And I don't know if you know this, but in the dying patients, sometimes dehydration in the terminally ill patient has been shown to actually decrease the pain and be more comfortable than when a tube feeding is introduced. Did you guys know that?
No.
Yeah. Typically, hospice care or palliative care, maybe in the home, maybe in long-term care facilities, maybe in a hospice center. Okay, and hospice is the end stage of life. Okay, according to the World Health Organization, the WHO, the goal of palliative care is to improve the quality of life. That's what palliative care is. Okay, palliative care is trying to improve the quality of life when dealing with a life-threatening illness, just trying to help them be comfortable or relieving the symptoms. Okay, typically in hospice, the patient has a prognosis of 6 months or less. Okay. So what kinds of physical support might we see? Alleviate pain, reduce the air hunger, improve sleep. Examples of social support, maybe facilitate relationships that may be strained or neglected that the patient wants to mend. Updating a will, saying goodbye. Spiritual support, finding peace with God or whatever their higher power is through a chaplain or a spiritual advisor. Okay. And in hospice care, hospice nursing, well, in all nursing, we need to be able to understand the stages of grief and be able to know what stage these families are going through. Right? So in the initial phase of denial, we should stay with the client, stay with the patient, right? Remain with the family member. They're in total denial of what's going on. Maybe in acceptance towards the end, they've gone through all the stages and have finally accepted. I don't know if you've ever watched anybody go through the full stages of grief. It is like textbook. Anger, bargaining, depression, acceptance. It's textbook, right? Maybe providing information needed for decision making, maybe in the bargaining stage.
Professor, I have a question.
Yeah, go ahead.
So, about the stages of grief, isn't it true that like they go through different stages, not stage 1, stage 2, but they can be like in bargaining, then they can go back to
All the way
denial?
out. Yeah, absolutely. Absolutely. Everybody handles grief differently. You know, somebody may, I had a family member who passed away a couple of years ago. One of my brothers stayed in denial while the rest of us moved way down to acceptance. You know, and there are stages. People move through them in different ways. People take longer to get through different stages, may take a step back, like you said. Okay. As far as making decisions for the family, okay, that's not our job. Okay, that removes the autonomy of the decision making from the client. Okay. The hospice client is obviously has feelings of loss of control. They cannot process all the changes that are going on. The last thing we need to do is I think you should do this, or you should do this. That's what's called autonomy. We want them to be autonomous in their care, so as long as they can be. Okay? And that involves trust, and it also involves therapeutic communication. What's therapeutic communication? You've learned this in your other classes. What's therapeutic communication?
Open-ended.
Open-ended question.
Mhm.
Is it
avoid
still trust?
Non-medicated interventions.
Not making any assumptions.
Yep. 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 Open-ended questions. Avoid making assumptions. Don't offer platitudes or pleasantries. You know, we don't want to be saying to a dying patient, don't worry, everyone dies. You're not being punished. Or I'm sure God will forgive you. No, no. All right. It's what we want to do if they're making statements like that is we want to be in touch with a spiritual advisor who can have that in-depth discussion with them, trying to answer those questions or talk through those concerns. Okay. Pain control. Pain control is possible and expected. One of the things we're not worried about with the end of life client is addiction. So if you're the hospice nurse or you're caring for the client and their pain doesn't seem to be managed appropriately and they're still in pain, it's okay to call the doctor back and tell them what's going on. Okay. And maybe they need to increase their pain medication or increase the frequency. We're not concerned about addiction and dependence at this point. Does that make sense?
Yeah.
So in the end, as death becomes more imminent, what do we observe? The client may spend more time sleeping, appetite fades, oral intakes fall, urine output decreases, incontinence may occur. Okay, their vital signs change, right? Respirations become shallow and irregular. Okay. Providing hospice nursing care is mentally draining for the nurse. It's important to understand our own beliefs and attitudes regarding death prior to the beginning to work in this field. So hospice nursing is a calling. It really is. And anybody have any questions on that? Let's move into faith and spirituality and pull culture into this. Okay, part of culturally competent care, as we talked about a little bit ago, requires that we as nurses have an understanding of our own culture and that we are aware of any biases or stereotypes that we have. We need to understand, this is culture now. We need to understand that each individual is unique. We can't make assumptions. Our culture is not any more important or above anybody else's. And everybody's traditional health practices, values, and beliefs need to be respected. And like I said earlier, trying to incorporate into the plan of care. The other thing about cultures is that some cultures are past-oriented, present-oriented, and future-oriented. And that makes a difference in how you approach their health plan. Okay, so if past-oriented, you're not really concerned with the future. So if a client is having to schedule future visits for doctor's appointments, that's not their expertise. They may need some help doing that. Right? Present-oriented, maybe the teen pregnant mom. Think she's thinking about the future? No, she's living in the present. Okay, and then you have the future-oriented cultures. Okay? So future-oriented cultures make sacrifices in the current present time in order to achieve their future long-term goals. So really what I want you to understand is that different cultures have different time priorities, past, present, and future. Okay? And long-term, how is cultural competence attained? I'm still working on cultural competence. Okay? Cultural competence is finally attained when nurses make a conscious attempt to learn about other people of diverse cultures, and you try and look at the world through their eyes. Okay? One of the roles that a community nurse may have, it's called a faith community nurse. Okay. This is a nurse that is within the congregation. And that congregation is whatever religion, wherever you practice, Catholic, Jewish, Muslim, mosque, temple, church, whatever. Faith community nurse is a nurse that works in that congregation, more of a holistic primary nurse, focuses on teaching or support groups or home visits. And the addition is the addition of the spiritual piece to their care, right? Much more community oriented focused. Okay. They may be volunteers. It may be a paid position, whatever the congregation needs. If they need support groups, if they need health fairs, if they need home visits to new parents, it's all dependent on what the congregation and the leadership of the congregation think the community needs. All right. Most of their practice is on health promotion, health maintenance, health coordination. Okay, while incorporating spirituality and religious practices. Okay, we know that religious and spiritual beliefs have a significant impact on many of our clients and their ability to cope with acute or chronic illness. Maybe the birth of a child, the death of a family member. Populations with strongly held religious and spiritual beliefs benefit from this incorporation of the faith community nurse into their practice. Okay. So there's a difference. Religion in, well, there's two terms, religiosity and spirituality. Okay. Religiosity is practicing your faith, whatever your faith is. All right. Your traditions, whatever denomination that is. Spirituality, on the other hand, is whatever your attitude is reflecting the higher power. Okay. Does that make sense? So religiosity is focused on the religion you practice. Spirituality is your more big picture overview on whatever that higher power looks to you. Make sense? And the last topic I want to cover is ethics. Ethics is one of the foundations of nursing. It's actually one of the foundations of life. Okay. We face ethical dilemmas and ethical issues in every part of our life, whether it be work in nursing, whether it be family life, personal life, work life, school life. What is ethics? Doing the right thing, right? That's what ethics is. Okay, the first step of ethical decision making is identifying whatever issue we're going to face. Think of assessment. Think of your ADPI. We have to figure out what the issue is before we can decide to talk about it and make some decisions. So this whole first paragraph is about nursing process. First, you figure out what the issue is. Then you obtain the relevant facts, approaches, decision, implementing, evaluating. Ethical decision making is very complex, right? There's ethical theories, there's ethical principles. What happens if you violate ethical principles? Okay. The other thing that you may get asked to be involved in is an ethics committee. I was involved in several ethics committees when I worked in the hospital. Okay, our goal is an ethics committee, right? Providing policy recommendations, doing consultations with specific cases. The things we did not do is provide care for the clients or provide emergency approval for a mental health commitment. That's not the committee. The committee is to discuss cases. Okay. Another term that's pretty common in the ethics arena is moral distress. All right. So moral distress. when you're unable to act according with what you're supposed to be doing. All right, moral distress can be a huge burden for nurses. Okay, it can lead to burnout. I mean, for example, what if your patient load is too high and you're figuring, how am I going to provide competent care to all of my patients? You have moral distress. Okay? It's important to face the feelings the negative feelings that come along with moral distress. Okay? Otherwise, it's going to affect you long term. Okay, some examples of moral distress: end of life decisions, patient load too high. Maybe you had a lot of moral distress over the COVID-19 visitor restrictions. Okay. One of the ethical principles is called beneficence. There's 4 ethical principles. They're in here. Beneficence is the first one. Requires that we do good. So if 10 of us were performing vital signs, 10 of us would do it the same way. Does that make sense? Requires us to do good within the circumstances. So for example, pain control, ensuring adequate pain control is an example of beneficence. Doing good. Distributive justice is another one. Distributive justice means that we all have the same access to healthcare. Okay? Another one is autonomy. Autonomy is, we already talked about it, the patient's right to be involved in their care. These are all in your notes in the book. The 4th one is non-malfeasance, which is do no harm. Okay, so do no harm. Let's say you're cathing someone and you accidentally contaminate the sterile field. What do you have to do?
Get a new one.
Report it.
That's non-malfeasance. Do no harm. Make sense? Advocacy is big in ethics. We as nurses are advocates for everybody. Nurses just have that high on a pedestal kind of reputation. We're advocates for everybody, our clients, our family, our kids, right? Advocacy in nursing means that we utilize all of our information and resources to benefit the client. We're acting in the client's best interest, obviously maintaining confidentiality, and then being impartial and carrying out the preferences and goals of the client with diligence and competence. We want to make sure our clients have all the information needed to make any decisions. Another issue with ethics is let's say you're no longer able to care for a client. You can no longer provide high quality care due to moral distress or an ethical dilemma. You can't just abandon the patient. The goal is to arrange for a suitable alternative before you can stop caring for the client. Here's an example. Okay, what about you're working in a home health environment and your client is making unwanted sexual advances? Okay, and you cannot work in that environment anymore. Obviously, you have to transfer the care to another competent nurse or other home health agency. Right? Here's another example. In the hospital, you're assigned to a patient you learn is a murderer. They came to the hospital from prison. You've had a family member that was murdered in the past year. You know you can't be objective and provide unbiased nursing care. You need to transfer that care to someone else. These are ethical dilemmas. Okay? Your duty is to provide the highest quality and competent care using your ethical principles. You're already using your ethical principles. You just didn't know that that's what they were called. All right. You can't let your decisions be guided by fear, liability. Okay. Ethics plays a big part in nursing, actually in all of our daily lives. Would you agree? Okay. Yeah. Yeah. Really important. Really important. I mean, ethics is doing good. That's why we're in nursing, right? We're the caregivers. I mean, yeah, you've got a percentage that maybe they're at the great majority of us are caring, competent nurses doing the best we can do within the scope of our practice, following the ethical principles, right? But ethics is a tough one. All right, I need to jump in real quick and open up your quizzes. So hang tight for 1 second. And then we're going to take quiz 3. Okay. They should all be accessible now. So let's see. It is 2:05. So let's go till 2:20. Okay, that's 15 minutes. I need you to complete it in 15 minutes. There's 10 questions. You got to stay on camera because it's a key graded assessment. Do your quiz 3, and then at 2:20, we'll come back and we'll review it. Okay, if you're done, you got to still stay on camera. Okay, but you don't need to return back till 2:20. Okay, but keep your cameras on. Okay, any questions? Take your time. Got plenty of time.
You said after we're done, we still have to stay or we can leave?
No. Stay on camera because we're going to go over the quiz.
Okay.
So stay. Okay? And you don't need to send me emails that you're done. Don't even worry about it. Just hang tight. Okay? I'm going to mute myself so that everybody can do this in peace and quiet.
Okay.
Hey, how's everybody coming? One more minute. Hey, remember, everybody needs to hit submit. Okay, everybody put their cameras back on, please. Debray, did you get my message? Or Brasia, where are you?
Brigay.
Yeah, it's just
Yes, I got your message.
Yeah, just log off and then send me a time that you can take it in the next, it'll be 10-15 minutes.
Okay. Okay.
All right. Yeah, bye. All right, let's go through it. Everybody submit. Tina, did you submit? I didn't have you, and Sariba, I didn't have you. Did you
Yes,
both
I did.
Okay, Sariba, did you submit?
Yes, ma'am, I did.
Okay, good. Okay, let's go through it. Okay, let's see. All righty. Okay. The school nurse is engaging in primary prevention program. Which intervention is appropriate? Primary.
Discuss.
Exactly. Discuss where and how to obtain ongoing contraception. What is C? Primary, secondary, or tertiary?
Tertiary.
Why?
Tertiary.
Because you educating.
Yeah,
Because they-
they already have the condition.
They
Correct.
got there already.
Correct. What about D? What's D?
That's
Primary.
D.
Secondary. D is
Screening.
Primary.
D's tertiary. Why?
because it's the pamphlet describing your diet. It's teaching as well. It's educating as well.
Right. But they're also pregnant.
You're already pregnant.
Right?
Oh, yeah.
Yeah,
Yeah.
it said appropriate prenatal diet.
Yeah. What about A? What's A?
Screening.
It's secondary.
Perfect. Great.
Screening.
Great. Yeah. Great. Which counseling is appropriate to provide a pregnant adolescent?
A,
Why?
cause she don't wanna get she don't wanna get an infection while she's pregnant with her, she don't wanna have a disease while she's pregnant with her baby. Pass
Absolutely.
it on.
And the other three are actually incorrect. They're not maintaining your usual diet. We
Yep.
don't want prenatal care established in the second trimester. We want it in the first.
Yep. Mhm.
And adoption decisions don't have to be made right off the bat. So the other
No.
three are actually incorrect. Which intervention should be prioritized for a child who has witnessed a violent crime? Before you answer, what's the key word in the question?
Prioritize.
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 So this is a good example of a question that maybe some of the other answers look like they could be correct as well, right? And it's not a select all that apply. So what would you do in that case?
Get them a referral for
A
mental
referral.
health.
No, I'm sorry about reading the question. You would go back to the question and reread it to see if you missed a key word or a phrase or a cue, right? Because assess for family history of post-traumatic stress disorder, maybe.
That's something that you would want to do, but it wouldn't be something that you would want to do first.
Exactly, Jacob, exactly. So what's the right answer?
In referral for mental health counseling and services.
Correct, correct. And if you do that first, then the other three could be accomplished through those mental health counseling services, right?
Right.
So it's asking, what do you do first?
Right.
Hey, which nursing intervention reflects secondary prevention for mental health?
Screening.
Screening.
That's a giveaway. Screening, right? Screening for depression and anxiety. Okay, what is B?
Tertiary. Cause you're teaching them stress reduction.
Oh, is it primary?
Yeah, it's primary because you're
Teaching.
teaching them techniques.
Okay, prevention.
Remember, guys, remember, I told you, I went through this in the first beginning of the class. Education and teaching happens at all levels. Okay, don't be caught off guard for education to only be a primary. Okay, think about it. In the primary, we're teaching how to prevent, right?
Mhm.
Secondary, we have identified them as high risk. So we're still teaching because we want to kind of stop the progression. We've screened them to be high risk for something. So we're teaching how to reverse that, right? Tertiary, we're still teaching because they have something. So we're teaching them how to manage it, right? So don't get caught up on education just being at the primary level. Okay, what is C?
Tertiary.
Why?
Because it's for side effects for an antidepressant, so that's something that they already have.
It's something they already have. What is D?
Tertiary as well.
Because they already have PTSD. Which nursing assessment is the most important for clients abusing oxycodone?
Apnea.
Yeah.
Apnea. This is a safety question. This is your ABC question. Yes, the others might exist or might be present, but what is the question says most important? Get that?
Yep.
Number 6, which reflects tertiary prevention and substance abuse? Tertiary.
Arranging adequate support groups.
Arranging a day.
Exactly.
The recovery part, let you know they already have it.
Right. They already have some kind of substance abuse. So arranging a support group to promote recovery. What is A?
Screening.
Secondary.
Secondary screening. What about B? What's B?
Primary,
Primary.
Why?
because you're giving out information.
You're trying to prevent something before it happens. Right? What is D?
Secondary?
Tertiary.
Secondary.
Wait, no, secondary. I'm sorry.
Secondary. Right?
Mhm.
Okay, which nursing intervention reflects non-malfeasance? What's non-malfeasance?
Doing
Doing
the
it.
Do no harm.
No
Do-
harm.
Do no harm.
Okay.
So you want to obtain a new catheter.
Yeah. Do no harm. The hospice nurse notes that the client's pain is poorly controlled despite a fentanyl patch and as needed sublingual morphine. Which intervention is appropriate?
Or the
Notify.
healthcare provider.
Additional pain management.
Right. So like we said in class, we're not worried about addiction here. Okay. C is totally inappropriate with regards to hospice nursing, right? And then we would not remove a fentanyl patch and apply a new one at the same location, right? You guys know that from
Right.
Med-Surg.
Right.
Client tells a hospice nurse, "I do not understand why God is punishing me." Which response is appropriate?
Yeah.
Ask them if they have a
Yeah, call the
pastor.
Pastor.
Call the pastor, because a lot of students choose A. Let me pray with you for forgiveness. Well, that's not up to you to decide whether they want
Right.
forgiveness or
Yeah.
not,
Right.
right? Dying is just a normal part of life, not punishment. That's really not
Mhm.
up to us to say. And then if you ask what makes you think you're being punished, maybe that's gonna make them communicate negative things, or right. And again, this is why I said in our section on spirituality, this is why we ask for spiritual advisors. Okay. The spiritual advisors are way more competent to have this kind of conversation with the client, right?
Yeah.
And then number 10, a client with metastatic cancer has made the decision to stop all therapies. Which statement by the nurse reflects a respect for the client's autonomy?
Would you like my help in sharing the decision?
Yeah.
With your family. Yeah.
Yeah. Why would we say B? They've already said they don't want any treatment. And then C, we're just questioning we're being judgmental. We're questioning what they want.
Mm-hmm.
And C, and D, they've already said they don't want any treatment. So chemo, why would we be talking about chemo? Right?
Yeah.
So, okay, how'd you guys do? I saw a lot of 10s. Did you guys do okay?
Yes, ma'am.
Good.
No.
This was a big class. We covered a lot. Did you learn a little bit about each concept?
Yeah.
Okay. So that's it for today. I hope you guys have a good rest of the week. You know where to reach me if you have any questions. If you still need to reach out to me to review the exam, please do. I've got a lot of tutoring on my calendar this week, so we'll make a time work. The other thing too is we started at-risk meetings last week. Okay, you should be familiar with them. But if students are below a 78 or have attendance issues or have missing homework, I and all the professors, we're required to complete at-risk reports. These are done weekly on Sundays and Mondays, and they're sent to your deans. Okay, and then every other week we meet with campuses. So this week we meet with half the campuses. Last week we met with the other half of the campuses. In these meetings, we sit with your deans and we review your performance if they have an at-risk report from me about you. So if your deans are reaching out and contacting you, hey, why have you missed 2 classes? Or why haven't you turned in this assignment? They know that because of me. Okay, and all professors are required to do this. Okay, so it's not tattletaling or trying to get you in trouble or anything like that. This is part of the monitoring of students so that we can come up with a success plan to make sure you're successful in the class or any class. Okay, so I don't want you to be caught off guard if, hey, how did she know that? Or how did he know that? Well, that's me. Okay, or your PEDS professor or your Med-Surg professor. We're all required to do that. Okay?
Yep.
So I hope you guys have a great rest of the week. Reach out if you need anything. I have several tutoring sessions scheduled, starting now. So I'm going to log off and get with these students. If you're the next student on, well, Denisha, you need to stay. Let's see. Everybody else can go except the ones I'm tutoring.
Okay.
So have a good rest of the week.